All right, perfect. Thanks so much, everyone, for joining us for this month's session of um, Africa Calls Cytology. I'm going to let Dr. Lomo take over and introduce Dr. McIntyre for today. Just a reminder that if you want to ask questions, please use the Q&A box. If you have a technical problem, you can use the chat box. Our sessions are recorded and they'll be available on the ASCP grant page, which is always the same. You can just go there, and when it's available, it will show up there. And just as a reminder, for next month, we're going to have one session, which is an Africa Calls Histology session, which is a very special session with leadership from Google, who are going to demonstrate two of their new artificial intelligence development tools that they want to start working with our African and other foreign colleagues to use to develop your own resources and tools locally. So that'll be on the 24th. So Leslie, let me turn it over to you to introduce Dr. McIntyre.
Great. Thank you so much, Dan. Greetings, participants. Welcome back to today's session, the first one of Africa Call series in 2024. My co-moderator, Dr. Ali Lowe, and I would like to welcome and introduce today's guest speaker, Dr. Patrick McIntyre. Dr. McIntyre obtained his medical degree from Rush University Medical Center in Chicago, Illinois, and went on to complete anatomic pathology residency and breast pathology fellowship training at Weill Cornell Medical Medicine and New York Presbyterian Hospital in New York City, as well as a cytopathology fellowship at Loyola University Medical Center in Maywood, Illinois. He then joined the faculty at Cleveland Clinic, where he is currently the director of the breast pathology service. Dr. McIntyre has authored multiple original research articles in the areas of breast pathology and cytopathology, and is a co-author of two chapters in the Paris classification system for reporting urinary cytopathology. And so we are so fortunate to have him speak to us today on the Paris system for reporting urine cytology, including updates and benign limits. So without further ado, I will turn it over to Dr. McIntyre. Thank you.
Great. Can everyone hear me? I think so. So thank you very much for that kind introduction, and thank you very much for inviting me to this very special program of African Calls and Project Echo. So here's a picture of me, and here are my titles. And so for today, the talk is really split into two separate talks. The first, we're going to review the Paris system for reporting urinary cytology, which first came out in 2017 and then was updated in what people call now the Paris system 2.0 in 2022. So I'm going to focus on just going through the Paris system and then what is new in these updated versions. If you've not seen the updated Paris system, I recommended reading it. If anything, for the first chapter, which was written by Stefan Pambuchian, and he goes through the history of urinary cytology and is quite excellent. For the second half of the talk, it's going to be a little bit more practical. And since the Paris system for reporting urinary cytology focuses almost entirely on diagnosing high-grade urothelial carcinoma, it's very important to recognize what's benign and what's malignant. So this is going to be a case-based exercise. It's meant to be interactive. We don't have polling, but that's okay. And so we're going to see if you can differentiate between what's benign, what's malignant, and then in the process, we're going to review some of these benign mimics of high-grade urothelial carcinoma and some of the new data regarding high-grade urothelial carcinomas. So in order to start, we should talk about indications for urinary cytology. So the most common reason for having a urinary cytology specimen is to establish a diagnosis in symptomatic patients. These patients usually present with hematuria. Obviously, there's a lot of reasons for patients to have hematuria, so the rate of malignancy is rather low, about 5 to 10%. The other reasons for having urinary cytology specimens is to screen those patients that are considered high risk. Those patients include those that had exposure to industrial chemicals and different metals, etc. Another common reason, which we see frequently in the United States, is follow-up for patients with high-grade urothelial carcinoma. So a diagnosis of high-grade urothelial carcinoma requires a lifelong follow-up. So these patients will have urinary cytology specimens pretty much for the rest of their life. It also is used as a complement to cystoscopy and biopsy. The reason it's complementary is because it can detect hidden or small lesions, so diverticuli in the bladders, but also, very importantly, urinary cytology is important for the upper urethelial tract that includes the ureters and the renal pelvis. Of note, urinary cytology is actually the most reliable method for detecting high-grade urothelial carcinoma, and the reliability is greater than biopsies. This is one of the few cytology specimens in which the reliability is greater than surgical pathology. So, why do we have the parasystem? And the whole reason is about atypia and urinary cytology. So, before the parasystem was implemented, the data in review studies says it's about 10 to 20%, but as you'll see in the individual institutional studies, it can be upwards of 60% of urines were classified as atypical. And what we noticed is that there's a considerable amount of inter-observer variability amongst pathologists. So one pathologist's atypical is not another person's atypical. And the reason for that is there's no standardization in what cytomorphologic features constitutes an atypical call. So there's some need for standardization of the cytomorphologic features. We need to reduce the atypical rates. There's a wide variations depending on the institution that you're at. It says 2 to 31%. Again, I've seen it go as high as 60%. And what does that mean? Well, if you have an atypical rate of 60%, that's very unhelpful to urologists because they don't know what that means, right? Do I act on this or I don't act on it? And what ended up happening is atypia was called so much that it was considered negative by urologists. However, malignant follow-up rates can be as high as 23 to 68%. So what we needed to do was reduce the atypia rates, and we needed to standardize what is atypical and what is not atypical. And because there was so much atypia out there in these urinary cytology specimens, ancillary studies such as FISH emerged, and that seems to really have kind of fallen out of favor with the implementation of the parasystem. So here is a study that was done at the Cleveland Clinic to demonstrate atypia rates in different pathologists. So what you have here is 12 different cytopathologists. They're board certified. They looked at 23,000 urine specimens. Each bar represents a different cytopathologist, and the y-axis is the atypia rate. They are clumped into 3 different cohorts based on years of experience. So less than 5 years is yellow, 6 to 15 years is orange, and greater than 15 years is teal. And as you can see here, there's a wide variation in atypical rates. It ranged from 8 to 28%, with the average being 14%. But as you notice, when you look at the different experience, it really doesn't seem to matter what is considered atypical. In fact, in group 3 with the highest experience also had the highest atypical rate. And so it really is more dependent on the individual threshold level for atypia. We also looked at the individual pathologist diagnostic categorization. So on the right-hand side, you can see the percentage that was called atypical, the percentage that was called negative, suspicious, and malignant, and then the individual pathologist. The left-hand side is, or I'm sorry, the y-axis is what's the percentage. And so, for example, pathologist number 1 doesn't call anything suspicious. Pathologist number 3 doesn't call anything suspicious or malignant. Pathologist 4 doesn't call anything malignant. And really what you want to, where you want to be as a cytopathologist when you sign out urinary cytology is pathologist 2, where you have a high rate of negative cases, a smaller rate of atypical, and even smaller rates of suspicious and malignant. So there is some obvious need for standardization. And so they needed well-defined and reproducible diagnostic criteria. This would help uniform inter and preserve departmental communication. And the reason that you have to have this reproducibility is because you need consistent prognosis and management, which will lead to optimal patient care. So the parasystem was devised in 2017 with its mission. With its missions to create a cytology system that is considered highly reliable. The whole idea was to develop a system in which there was decent risk stratification so that the urologist could look at the different diagnostic category, determine the risk, and decide clinically whether or not they should do cystoscopy or just do follow-up. In order to make this system useful, the authors decided to focus exclusively on high-grade urothelial carcinoma. You'll notice that the negative category for the Paris system is negative for high-grade urothelial carcinoma. That was a topic of quite high debate. They decided to put the low-grade urothelial neoplasm in its own category. The reason they did that is they wanted to reduce the atypia rates, and it's very, very difficult to make a diagnosis of low-grade urothelial carcinoma or low-grade urothelial neoplasm on urinary cytology. In addition, the low-grade urothelial neoplasms often present as fungating or polypoid masses within the urinary bladder, which can easily be seen on cystoscopy. So it was decided that urinary cytology should focus entirely on high-grade urothelial carcinoma. These are the carcinomas that are flat, that are invasive, that are not seen in cystoscopy. And because they focus exclusively on high-grade urothelial carcinomas, they were hoping that they could reduce the atypia rate significantly. So the aims of the Paris system was, as I mentioned, have defined diagnostic categories, and they wanted this to be based on pathologic evidence. Again, one person's atypia was not another person's atypia before, and so by having these diagnostic categories and standardized cytomorphologic features, they are hoping to reduce that inter-observer variability. And then they wanted to test this criteria after it was published for both reproducibility, accuracy, and to see if atypia rates in fact went down. So in 2017, the Paris System 1 came out with the 6 diagnostic categories. Negative, as I mentioned, negative is not just negative for urothelial carcinoma, it's negative for high-grade urothelial carcinoma. That distinction is quite important. There are 2 indeterminate categories, which we'll go over specifically. There's atypical urothelial cells and suspicious for high-grade urothelial carcinoma. The difference between these 2 is based on qualitative cytomorphologic features of the atypical cells, and we'll talk about that. The suspicious and high-grade are differentiated by a quantitative factor, so the number of cells differentiates suspicious from high-grade, because they wanted to pull low-grade out of the positive category and not in, and some people fought against putting into the negative category. Low-grade urothelial neoplasm was its own category, and then of course there was an other that included primary and secondary malignancies. So the question is, how did the Paris system do? So there were lots and lots and lots and lots of studies done. I've done a couple of these. Here are examples of a few of them. And the whole idea of the Paris system was to reduce atypia rates so that atypia had meaning for the clinicians. And so on this column, here you see the pre-TPS atypia rates. It's in a percentage, and then in the parentheses is the number of cases. And you can see it varies considerably, but there are very, very high rates here. There are a number, 54, 59, 44, 23, 34, 29, 41. So you can see why the clinicians were a little bit frustrated when they got an atypia call pre-TPS, because they don't know exactly what that means, especially if 60% of the cases are called atypia, which is why they treated it as negative. In the next column over is the atypia rates after the implementation of the Paris system. And you can see there are still some that are high at 41, but many of them are much lower, 9%, 9.5%. And the delta is the last column on the right. And you can see that both almost every study shows a negative value, which means there was a drop in the atypia percentage. And some of them are at very significant magnitudes where they saw a 41% drop in atypia, 21% drop in atypia, 25% drop in atypia. So this is very, very good data suggesting that the Paris system was very helpful in reducing atypia rates. So TPS 2.0 came out in 2022. Again, I highly recommend reading that first chapter. I think it's a masterpiece, to be frank, but nonetheless, low-grade urothelial neoplasm was removed and it was placed into the negative category. So now there are only 5 diagnostic categories. In red are some of the changes. So the unsat, we used to have an unsat, but there was no guidance into what that meant. There were a few studies out there. So unsat is based on the type of specimen. So whether it's voided or instrumented, a voided urine has an unsat based on the volume. So if you have less than 30 millimeters, that's considered unsat for a voided urine. The instrumented urine, those are the washings. That's based on cellularity, so anything less than 10 to 20 cells is considered unsat. And the reason it's important to have this unsatisfactory category is if you look over to the right, the rate of malignancy is 0 to 16%, which means there are malignant high-grade urothelial carcinomas in these unsatisfactory categories, which means they weren't on the slide, but the patient had cancer. So it's important to have this unsatisfactory category so that the clinicians know that they need to go back and that there is, in fact, a rate of malignancy. As mentioned previously, the low-grade urothelial neoplasms were moved into the negative category. There still is a rate of malignancy in the negative category. It's likely due to sampling error. Other reasons to have negative are stated there, but we'll go through them individually. As I mentioned, there are two indeterminate categories, atypical and suspicious, and it's qualitative between atypical and suspicious, with the most significant being the NC ratio. So that's the nuclear area divided by the cytoplasmic area. For AUC, for atypical, that's greater than 0.5, but for suspicious, that's greater than 0.7. So less cytoplasm, more nuclear cytoplasm per cell in the suspicious category. The nuclear features, and again, we'll go through them all, that are important in the parasystem are hyperchromasia, coarse chromatin, and irregular nuclear contours. The difference between suspicious and high grade is not qualitative. It's the same looking cells, right? They have the same cytomorphology, but it's really the quantitative amount. So suspicious is less than 5 to 10 viable cells. Not surprisingly, it has a very high rate of malignancy, up to 94%. And then high grade is greater than 5 to 10 viable cells. So here's a little bit of a algorithm decision tree. The first decision point is if it's greater than or equal to 0.5, then that doesn't include intermediate basal cells, and we'll look at that. If it's not, it's negative. And then if you do have greater than 0.5, you go to the next. Okay, is there a reason for atypia? If there's a reason for atypia, that goes into the negative category. Then you look at the nuclear contours. If you have two features and the NC ratio is greater than 0.7, then you look at how many cells there are. If there's less than 10, it's suspicious, greater than 10, malignant. If you only have one feature and it's greater than 0.5, it's atypical. And so you get very used to it. It looks a lot more complicated than it is. And once you do a lot of urine cytology, it becomes almost second nature. You know, you ask yourself, okay, is this 0.5? Is this 0.7? How do the nuclei look? How many are there? Your brain kind of instinctively goes through this algorithm, but here it is on paper. And that was done by Dr. Woodjep, one of my mentors. So what else is covered in the newest version of TPS? Well, we wanted to talk about some of the variances in the morphologic, the morphologies of the high-grade urothelial carcinoma. I worked a lot on this. We had to talk about degeneration, when to count cells and when not to count cells. And then also one of the areas that needed to be addressed was squamous atypia. What do you do with that? Where does it go? What should be mentioned? And these are questions that I got very commonly, so it was also addressed in the newest version. So as mentioned, this is the high-grade urothelial carcinoma. You can see it on the right, NC ratio greater than 0.7. And these cells have irregular nuclear contours, hyperchromasia, and some clumpy chromatin. And again, you need to have at least 5 to 10. Okay. So here are just some other key features that aren't necessarily in the parasystem. You know, it's nice to have single cells or these disorganized clusters. You know, they talk about the drunken honeycomb and pancreas. It's similar with urothelial carcinoma. Some of these tumors can demonstrate these pleomorphic bizarre cells as seen in the upper right, where you have these cells that are just obviously malignant tumor cells. They're very bizarre. Koi cells are these small cells with hyperchromasia and irregular nuclear chromatin, and you can see some of them on the right here. And again, all these cells need to have a high NC ratio greater than 0.7. But the problem with NC ratios is that as humans, we're really bad at them. So this is a great study done by Chris Vadenbush out of Hopkins, and he had pathologists look at different cells and then have them place them in a different category. And he found that on either end of the spectrum were pretty good. So at 0.3, 0.4, we're pretty good at saying, okay, this has a low NC ratio. There's a lot more cytoplasm than there is nucleus. On the other end of the spectrum, 0.9, 0.8, we're able to place those in that category. Where we struggle is in the 0.5 to 0.7, which is unfortunate because that's the category that matters for the parasystem, right? That's where you cut between atypical and suspicious. And so one thing that we have found helpful is keeping this little chart by your desk and reviewing the chart and asking yourself, okay, is this a 0.5 or is this a true 0.7? What I've noticed is a true 0.7, you think it's higher than it is. And so anyway, we measured the NC ratios of high grade and suspicious, and we measured every 10 just high-grade cells, and we found that the mean NC ratios were actually smaller. And so the reason for that is there's a wide range of NC ratios in these high-grade urothelial carcinomas. So here are two examples of high-grade urothelial carcinomas where some have lower NC ratios than 0.7. But what we notice is that within a given sample, within a given 10 cells, there was at least one cell that had an NC ratio greater than 0.7. And so, in high-grade urothelial carcinoma specimens, there's generally hundreds, if not thousands of cells. So you should be able to find, anywhere from, 5, 10, 15, 20 to upwards of 100 cells that have that ratio. But it's important to recognize that there is a wide range of NC ratios, even in these high grades. The cutoff is greater than 0.7, and that's meant for specificity purposes. They want to make sure that a high-grade call is a high-grade call, especially in upper urothelial tract carcinomas, in which the urine specimen might be the only positive specimen. Sometimes the clinicians will act on a high-grade urothelial carcinoma call in the upper tract, and you'll get a kidney and a ureter, and you just want to make sure that's positive. So the point of this slide is to say that while on average the NC ratios of high-grade urothelial carcinoma are below 0.7, you should be able to find individual cells that are greater than 0.7. And the reason that the system is built this way is for specificity. We'll address this later, but some new studies came out about hypochromatic high-grade urothelial carcinoma. It's obviously a clear pitfall, considering that hyperchromasia is one of the categories. However, in these cells, it still meets the criteria for high-grade urothelial carcinoma because there's a high NC ratio of greater than 0.7, as you can see in these pictures. Plus, it also has 2 of the 3 features, including coarse chromatin. This is generally seen at the periphery of the nuclear membrane, plus a regular nuclear membrane. So while these are a pitfall, they still fall under the criteria. Another specimen. So this is something that's been I reviewed this in the literature. This has been around forever. This idea of India ink, jet black nuclei, or high-grade urothelial with extremely dark chromatin. They look different than the typical, what I call traditional parasystem cell, as in they're very sickled, as you can see on the bottom here. It's kind of like a sickle. They're extremely dark, and they usually mixed among the traditional high-grade urothelial carcinoma cells. But it is something that you see, and as you said here, it's rarely the sole component, and it's generally seen in highly cellular specimens. But people often ask about, what do we do with these extremely dark sickled cells? And the truth is, it's actually a soft indicator for a high-grade urothelial carcinoma. But just remember, they usually don't come by themselves. They come with traditional high-grade urothelial carcinoma cells. So there are different histologic variants that you need to be aware of. Squamous differentiation glandular differentiation. They're often, these are just like the extremely dark nuclei, they're often associated with conventional high-grade urothelial carcinoma cells. However, there are pure squamous cell carcinomas of the bladder. They're extensively rare. They're associated with parasite infections or prolonged catheterization. I've seen one. And the differential diagnosis will obviously include primary and secondary malignancies. Two more aggressive variants is the micropapillary variant. Micropapillary, as you know, has standard micropapillary features that you see elsewhere, including lung and breast. This plasmacytoid is a very, very tricky diagnosis to make, and it's rarely made on its first occurrence. On the right-hand side, you can see the plasmacytoid urothelial carcinoma. They obviously have low NC ratios. They are small in size, so they're very, very difficult. Generally, they're diagnosed as AUC, and it's really not until the diagnosis is made on surgical pathology that you can kind of re-review the prior urines and realize that they are the same cells. But it is a very difficult diagnosis to make. The one thing I will note is that the nuclear features of these plasmacytoid urothelial carcinomas are that of high-grade urothelial carcinoma. They are irregular, they're clumps, chromatin, they're hyperchromatic. And so there is a degree of nuclear atypia, even though the NC ratios are low, in which should at least designate a call of AUC. Okay, so we have suspicious. Again, this is just a quantitative differentiation between high grade and then atypical, which we mentioned. This is a qualitative difference where you have lower NC ratios and just one of those nuclear features that we mentioned. These cells have to be non-degenerated and non-superficial. As mentioned, greater than 0.5. Degeneration is a common problem. Understanding, okay, is this a degenerated cell? Is this not a degenerated cell? There are some exclusions. So things that you can see are polyomavirus, stones, therapy, some reactive changes, and we'll go into this later. And so here, this is showing the difference between a non-degenerated and a degenerated AUC. So when you have this loss of nuclear membrane that you see on the left-hand side, they say don't call that as atypical, where on the right-hand side, you have this intact nuclear membrane with enlarged hyperchromatic nuclei. So you have enlarged nuclei. So you have an NC ratio greater than 0.5, so check, and hyperchromatic, check. So it meets the criteria. And then is it non-degenerated? And so if it's degenerated, you lose the nuclear membrane on the left, so it doesn't count. But on the right, the nuclear membrane's intact, so it counts, and that gets an AUC call. We can also see degeneration with high-grade urothelial carcinomas. You are supposed to only call non-degenerated cells with these features. And again, the whole point of the high-grade urothelial carcinoma category and being so strict on the criteria that's non-degenerated, that is greater than 0.7, that has two of the features, is we want specificity, especially in the setting of the upper tract. So atypical squamous cells is a question we get quite common. The most common reason to have atypical squamous cells is contamination, either from it's either vaginal contamination or the distal urethra. So this is generally some type of dysplasia from either the female genital tract, or in the men, the urethra can be from a condyloma. On the bottom right-hand side, you can see the standard cytomorphologic changes that you see in ELSO. However, if you see atypical squamous cells that do not have those standard features, so they are irregular, they are dark, this should not be discounted, and it should be noted, because in It is associated with bladder or cervical cancers in 20 to 30%. And occasionally isolated atypical squamous cells may be the only clue for the presence of an undetected or unsampled high-grade urothelial carcinoma. So if you have squamous atypia, it should not be discounted, and they're generally keratinized cells, as you can see. It's often difficult. You can either have severe atypia falling short, or equivocal features or insufficient cellularity, and it's associated with cancer up to 60% of the time. So basically, the point is, if you have atypical squamous cells, you need to report it. You need to alert the clinician. It can be associated with both cervical and bladder cancers. So that's the first part of the talk. The second part of the talk is I wanted to go over the high-grade urothelial carcinoma versus benign. And I have always found it easiest to differentiate the two when they're side by side. So this is going to be case-based, and essentially there'll be two cells on a slide, and you have to pick which one is malignant and which one's benign. And so for each case, there's 4 different cells. So you'll get the idea of it, and then just pick which one you think is malignant, which is benign. And if you can pick what the benign entity is, you get bonus points. Usually we pull this, but we're not pulling today, but it's still kind of a fun exercise. And I think it really highlights what differentiates benign from malignant rather well. So without further ado, the first case. So basically there are 2 patients here. One of these cells is benign, one of these cells is malignant. And you have to figure out which one. So this is patient 1, patient 2, and then I'll go through 4 different cells. And I'll go through them again. So it's kind of like an optometrist, 1 versus 2. Which one's benign, which is malignant? So patient 1, patient 2, one of these is benign and one of these is malignant. Again, same patient, 1 benign, 1 is malignant. And then the same. So we'll go back. So we have 2 patients. 1 is benign, 1 is malignant. Which patient is benign? Which one's malignant? Okay, so if you guessed patient 2 is malignant, you are correct. So the mimic in this case is polyomavirus. This is probably the most stereotypical benign mimic that we see. It's caused by the human polyomavirus JC and BK. It infects urothelial cells in healthy and immunocompromised patients. And it's, again, 4% doesn't sound very high, but if you're looking at thousands of urine samples a year, you see a lot of polyomavirus. It does have some clinical significance, but really only in immunocompromised individuals. So in healthy patients, it doesn't. Healthy patients can get JC and BK virus. In immunocompromised patients, it can be associated with hematuria and graft dysfunction. So Stefan Pambuchian, who wrote that, who I was talking about, wrote the first chapter of the parasystem. He always said that if you see large amounts of polyomavirus in healthy patients, take a step back and show that case, because he said there's something called a polyoma-like high-grade urothelial carcinoma, where you have these high-grade urothelial carcinomas that look a lot like polyomavirus, and they're often discounted because they look like polyomavirus. And basically, in healthy individuals, if they have polyoma, they should only have a couple. In immunocompromised patients, they can have many, many polyomavirus. But if you have a healthy individual that has a lot of cells that look like polyomavirus, you might be dealing with this subset of what we call polyoma-like high-grade urothelial carcinoma. So the cytomorphologic features of this mimic are very similar to that of the high-grade urothelial carcinoma, which is why it's a good mimic, right? You have these large, eccentrically placed nuclei. It can be you have these basophilic nuclear inclusions, which you can see here and here. It may completely replace the nucleus, that inclusion, so you can get these really dark nuclei that look glassy, opaque, or cloudy. And then you have this, what they call thickened nuclear membranes. And because they're so commonly seen and they look so much like high-grade urothelial carcinoma, they've been termed with the pseudonym of decoy cells. In this case, I was trying to show some cells that had that extremely dark or black chromatin. I mentioned it. This is now in the parasystem, as I mentioned, the Indian ink, black, jet black. Almost all the data on the extremely dark chromatin predates TPS. However, there was a study done that showed if you have these jet black or India ink, extremely dark chromatin cells in the background of a traditional high-grade urothelial carcinoma, it increases the diagnostic accuracy. So what does that mean? So that means if I'm seeing something that I think is a high-grade urothelial carcinoma, and then I also see these extremely dark nuclei in the background, that actually increases the likelihood that this is a high-grade urothelial carcinoma. So in that sense, it can be helpful. However, most of the data on this particular cytomorphologic finding predates that of the parasystem. So, all right, so that's case one. And so case two, again, there's two patients, one's benign, one's malignant. Try to figure out which one's malignant, and then we'll talk about the two entities. So this one's pretty tricky. So you have patient one and patient two. One of these is benign, and one is malignant. Okay, we'll go through them. I think I started here, not here. Okay, so you have to figure out which one of these is benign and which one's malignant. Is one benign or is it malignant? So in this case, number two is the malignant tumor. I helped you out by showing a mitotic figure at the end here, and then also in association with these hypochromatic nuclei, you can see there's kind of traditional TPS, high NC ratio, extremely high hyperchromasia, irregular nuclear contours, coarse chromatin associated with it. So you don't just have these hypochromatic cells, you have these hyperchromatic kind of traditional TPS cells, and obviously there's a mitotic figure. So the benign mimic in this case, the one that was on the left-hand side, this is non-specific reactive changes. This comes a lot to out of our cytopathologist as atypical. It's mostly because the nuclei are really enlarged, and they have these prominent nucleoli, which is kind of the reactive quote unquote atypia that you see in other benign entities. You know, the round and large open chromatin with prominent nucleoli. You can see the vacuolated cytoplasm. This is due to inflammation and injury. So, you know, obviously with patients who have hematuria, it's not unsurprising to have reactive changes, but you need to be aware of what reactive atypia looks like in normal urothelial cells, not to overcall it as atypical. And this is something that we see quite rarely. And what's difficult is this newly recognized hypochromatic high grade that I mentioned that's now in the parasystem under the high grade chapter. This was an Italian group. They were the first to describe it, I think, in 2020. And you can see here, I mean, these are pretty convincingly hypochromatic cells. However, they have biopsy proven high grade urothelial carcinoma, and they mimic pretty well. Or the non-specific inflammatory changes can mimic a hypochromatic high grade pretty well. But the difference is really the NC ratio is much higher. It's greater than 0.7. You have the irregular nuclear contours. And then one of the things they always mention is the prominent nucleoli are really at the periphery of the nucleus. So that is a giveaway. Renshaw came out. He was the second to describe it. And again, they're pretty convincing. And then, you know, we also did a study. But I guess the point I want to make here is even in Renshaw's paper on the left-hand side, you can see you also have kind of traditional high grade, especially this looks like a traditional high grade in the upper left-hand corner of A, urothelial carcinoma cell. And what we found is if you analyze all the cells in these hypochromatic high grades, they have plenty of the traditional TPS cells. So if you're questioning whether or not something's a hypochromatic high grade or a reactive, look for a background of traditional TPS like high-grade urothelial carcinoma. And obviously, one of the things Eva Wojcik would always say is that, criteria, she would say, some people use criteria as a crutch. They use it to not call something. She says, if you see something that's malignant, call it. Criteria is meant to help in borderline difficult cases. And you can kind of look here, these cells in any other context are so atypical that it would be very hard to imagine that is a cell undergoing some kind of reactive change. But again, you can look for the background of the hyperchromatic high grade. And they're not an insignificant quantity. So in the Italian paper, they found that it was about 17.8% of cases. Renshaw found it was 17% of cases. In our paper, we found that it was about 14% of cases. So that's pretty consistent. So you're thinking about 1 in 10, 2 in 10 of these tumors are going to have the majority component of the high-grade urothelial carcinoma as hypochromatic. Okay, that's all I have to say about that one. So we're on to case 3. And again, same game. This one's pretty tough. Which of these, so you have patient 1 and patient 2. One patient has a benign sample, one patient has a malignant sample. So patient 1, patient 2, one's benign, one's malignant. And again, some of these are meant to be challenging. I picked cells that look like each other for a reason. Okay, go back. Give you another shot at it. So what's benign? I'm going to check time here. Oh, I don't have a lot of time. I guess we started kind of late. So I'll go through this stuff pretty quick. So the one on the left is a seminal vesicle. They are seen. I've seen it a few times now. And the one on the right shows degenerated changes. And it's a high-grade urothelial carcinoma. And we'll talk about that. That's also in the literature. So the seminal vesicles can have these monstrous, that was the first cell that you saw in nuclei. They can show nuclear degeneration. In the last case here, you can see the phagocytosed spermatids. And then what really sets it apart is the lipofuscin. So this kind of golden brown intracellular pigmentation is quite characteristic of seminal vesicle. Some of the things that are intriguing in this particular case is the idea of cellular degeneration. So the cell on the left is a high-grade urothelial carcinoma undergoing cellular degeneration. And one of the papers that, again, Chris wrote, he was noting that the degenerative changes can result in this low NC ratio. So if you look at cell 2 here, I mean, it's pretty complicated, but they have a number of cells on the right-hand side here that show cellular degeneration, and you kind of get this low NC ratio. So when it's degenerating, the nucleus gets smaller, the cytoplasm gets bigger, and this can lead to, if you do strict guidance, a strict classification of the parasystem, this can lead to undercalls. And so this is where Eva Wojcik's saying that if you see a malignant cell, call it malignant, can come in handy, where if you stick entirely to the parasystem because the NC ratios are low, you can call something that's clearly malignant atypical when it's clearly malignant. But that is the point of this particular high grade, is that during cellular degeneration, you gain cytoplasm, you lose nucleus, and then all of a sudden your NC ratio goes down. And this is in your handout. I just wanted to talk about different pigments you see in urine, hemosiderin, lipofuscin. Lipofuscin you can see in lipofuscinosis. This is also a waste product. And then melanin. It's very important to recognize melanin. Melanoma of the bladder is uncommon, but you do see it. If I went back through our files, there are a bunch of cases. Of note here, the granules are all are made by complex polymers, and they're very small. They're 0.5 to 1, and they're uniform. So it almost looks like a dusting. And if you can see through the pigmentation, you can see that there is severe nuclear atypia, high NC ratio. So these should at least get flagged. But yeah, they're definitely tricky and hard to differentiate from something like hemosiderin or lipofuscin. So we'll move on. It's 10:20. I'll go through one more case and then I'll stop. So you have patient 1 and patient 2. One of these is benign, one of these is malignant. Just to give you guys time for questions. So one of these is benign, one of these is malignant. So if you guess one is the malignant, you are correct. So the mimic in this case is the iatrogenic exfoliation of cells. You see these in the instrumented urines. And essentially, these are pretty tough, and you have to get used to seeing instrumented samples, because once you see instrumented samples enough, your brain will automatically know it's instrumented. And the reason instrumented samples are so hard is because these basal cells, so you have an intermediate cell, a superficial cell, the umbrella cell, and a basal cell. The basal cells can have scant cytoplasm and very dark nuclei. And if you're not looking at the urine in its entirety and seeing the intermediate and superficial cells, and you're focusing just on the basal cells, you can easily overcall this as an atypical, because a lot of times the ratio will be greater than 0.5. So you have to take that in context of the entire specimen. And this is especially true in the upper urinary tract, where they'll often do instrumentation and they won't do biopsy. The upper tract, actually, the cells are actually smaller than the benign basal cells are actually smaller with higher NC ratios than that of the bladder. They actually come from two different, what do you call it? One is from the ectoderm and one is from the mesoderm. So they come from two different types of tissue. And but the point is the upper tract can have high NC ratios, more than that of even the lower tract. And so you need to be really, really careful. In fact, if you're ever going to call something positive or suspicious in the upper tract, I really recommend showing another person, because they may base a surgery, a nephrouretectomy, on that call. And again, it is a known pitfall. The reason they do it is because they can't do biopsies, and also as this shows, it increases the sensitivity. So there are some variants of high-grade urothelials carcinoma that we mentioned. And in this case, this was a plasmacytoid variant. So this is an actual biopsy of a plasmacytoid variant, and then the histology below. And you can see, it's pretty difficult. They maintain the cytomorphology, obviously, but what we found is that in patients that have possible CIS, it was only called 7, or in all of these patients, only 7 of them were called high grade, 8 were called suspicious, and most of them were called atypical or negative. And these high grades and suspicious were only called after usually a positive biopsy. And when reviewing the priors, most of them were atypical. So these are very difficult to make. And the reason is, if you look here, the NC ratios are very, very low. And we took 5 cases, and we found that the average NC ratios of these known, on the right-hand side here, of these known plasmacytoid urines are below that of a 0.5. So they actually don't even make the criteria of atypical. So it's mentioned in the parasystem for completeness sake, but they really don't follow the rules of TPS, and they often get missed. So with here, I'll stop. I really only had one more case, so it's no big deal, but I really appreciate the opportunity to speak with everyone. And here's the summary. So
Thank you so much, Dr. McIntyre. I don't see any open questions right now, and there are many thanks that are coming up into the chat. I wonder if you might want to go through your last case if you're willing to. Sorry for switching back. Thank you. It was a
Yes,
great
that would
talk.
be.
Yeah, bonus round. I don't always get to it. That's why I call it the bonus round. Let's
I
share.
love this game. It's really fun. Yeah.
Well, it's it gets kind of difficult to. Can you see it?
I see not in presentation mode anymore. I like see, and now I see the speaker mode. So swap it one more time.
I swap it. Oh, I'm hitting duplicate. All right, let's try it one more time. Swap. Okay. So this one is, so as we mentioned, low-grade urothelial neoplasms have been removed from TPS 2.0. That being said, they're still in the negative category and they can be diagnosed on urinary cytology. There are definite features where you can say it's suggestive of an L gun. And so we're gonna go through that. So in this round, what you want to do is figure out which one of these is a low grade. So again, it's going to be put into the negative category anyway, but there's still some very interesting findings in urinary cytology that I wanted to talk about in low-grade urothelial neoplasms, and it might be helpful to the clinicians if you can suggest that there is a low-grade urothelial neoplasm that could be the cause of hematuria. Maybe it's not papillary and they don't see it in the cystoscopy. So, all right, so we have two patients. There's only 3 pictures in this one. So we have 2 patients. One's a low grade and one is benign. So you have to pick which one is the low grade. Okay, so one's benign, and one's a low grade. And an extra point so you can figure out what the benign entity is. So one's benign, one's a low grade. All right. So if you guess number 1, you're correct. That is a low-grade urothelial neoplasm. The mimic is stone atypia. So if you look at Sebas's book, which is a great book, obviously, he mentions that stone atypia is a mimic for high grades, and the pictures in the book are quite convincing, to be honest. I mean, the cells look pleomorphic, they look coarse, hyperchromatic, and irregular. In practice, I have found stone atypia to look more like low-grade urothelial carcinomas. They're the most frequent cause of obstruction. They cause hematuria, which is the indication for the urine cytology specimen. What's helpful is the background, if there's neutrophils and lymphocytes, obviously, and blood, right? But what I find is these tight groups with the smooth contours really do seem to look like maybe there's a fibrovascular core in there. So on the bottom right here is an example of these tight groups and smooth contours. The low-grade urothelial neoplasm. So how do we diagnose these? Well, cytologically, they're very, very homogeneous. So you're going to see a bunch of these small little cells with these. You see these cytoplasmic tails, right? You see these cytoplasmic tails. They can be exaggerated, like the one on the bottom here, where you have this. It almost looks like a spermatid with like an extra long tail. The reason for that is it's pseudostratified epithelium. So you have on a fibrovascular core, you have some that are right near the fibrovascular core, so they would have a smaller tail. And then those all the way at the periphery of the fibrovascular cores have the longer tail. Basically, it's a cytoplasmic extension. So back in the day, I guess I can say that in TPS1, the L-gun lesions, which was a category, you had to have a papillary fragment with a fibrovascular core in order to call it, which almost never happened. One of the things that we noticed is that if you did a cell block in those cases in which you expected there might be a low-grade urethelial neoplasm, you were much more likely to pick up on the fibrovascular core. Again, that's more academic than anything, unless the diagnosis hasn't been made. So that's the only time I've seen cell blocks really be useful in urinary cytology. Let's see. So I wanted to talk about these cytoplasmic tails. So you can have urines, and when you get these urines, and they're very monotonous, as we said, they don't have that high of an NC ratio. They're rather low NC ratios, like around 0.5, but they all kind of look alike. And then you have these varying degrees of extensions. You see, like there's a little one here, a little one here. This one's a little bigger, right? This one's a little bigger, and then here's your this is the center, right? The really tall one. And then same here, you have these varying degrees of cytoplasmic extensions, a very monotonous appearing nuclei with these, they're kind of hyperchromatic and a little irregular. Even without a fibrovascular core, you can suspect that there might be an L-gun, in which case you can do a cell block, as you see here. The reason that these, and again, you can see the reason for these different lengths of cytoplasmic extensions or tails is on the bottom right here. You have like this one right next to the fibrovascular core. You can see the this is like 100x. You can see the cytoplasmic extension, but then the ones all the way on the end here, you have to imagine they have a cytoplasmic extension that goes all the way to the fibrovascular core, which kind of denotes this cell here. And so if you ever think that you might have a low-grade urethelial neoplasm and you, because of all the monotonous appearing cells with the tails, you can do a cell block and maybe prove it. However, it does go under the negative category, and you can say that these findings are suggestive of an L-gun. So anyway, the summary of the talk is urine cytology is best applied to the high grade, which is why the TPS follows the negative category is negative for high grade. Because there was so much inter-observer variability on what was atypical and what was not, TPS provided strict cytologic criteria in that algorithm that I showed. In the pre and post studies, we've seen the atypical diagnoses go down dramatically. The update, I mentioned the different updates, and then the mimics are challenging, but if you know what they are, you can recognize them and reduce your number of Atypia calls. So with that, I thank you for your attention, and I'm available for questions. I think we went over a little bit.
That was perfect, Dr. McIntyre. There is only one question in the Q&A, and it's how do you differentiate between papillary high-grade and low-grade lesions? Both have cores.
Yeah, so that's going to be based on the cytomorphology. So the high-grade urothelial carcinomas, whether or not they're papillary or flat, are going to fall under the same diagnostic category where you have to have an NC ratio greater than 0.7, and then 2 of the 3 nuclear features, hyperchromasia, coarse chromatin, and irregular nuclear contour. So the presence of a papillary fragment just means that there's something papillary in there. The cytomorphology is what's going to differentiate between a high-grade urothelial carcinoma and a low-grade urothelial carcinoma. That being said, you can almost sometimes pick up on the different. Sometimes when you see a high-grade urothelial carcinoma that has those cytoplasmic extensions, you can say to yourself, I bet you that they saw a papillary lesion in the cystoscopy, and I bet you that the surgical pathology specimen is going to be a high-grade papillary as opposed to a CIS or flat. So sometimes you can tell the difference between the flat versus the papillary high grades, but the distinction between a high grade and a low grade is going to be based on the standard TPS criterion of high grade.
Thank you so much, Dr. McIntyre. That was a really informative session and really great fun examples. Thanks, audience, for your participation in grading those cases as benign or malignant. And hopefully we will see many of you at our upcoming histology session where Google's going to be teaching us about their algorithms. Thank you all and hope to see you soon. Thank you again, Dr. McIntyre.
Great. Thank you.
Dr. McIntyre.